Good day, everyone. This is Xanda Hilger, and I'm with the North Central Texas Caregiver Teleconnection that's sponsored by the North Central Texas Area Agency on Aging and the Dallas Area Agency on Aging. Today, we're talking about a topic that most people who've ever had someone in a hospital or in any kind of facility find is one of our biggest challenges, which is engaging with, talking with, speaking with, communicating with people in these facilities. And our speaker today has had a lot of experience with this as a professional and personal. So I'd like to introduce G.J. Hodson. He has a master's degree, is a queer disabled caregiving educator, bridging research and lived experience. After serving as a 30-something solo care partner of his adoptive grandfather, he earned a master's degree in sociology while facilitating care support groups. They have facilitated workshops for the National Institute on Aging and the LGBTQ plus Elders Conference, and will be a panelist this fall at the Gerontological Society of America's annual meeting. She currently serves on the Planning Council of Texas Pride Health Collaboration and in the research collaborative of the National Alliance for Caregiving. And we have, if you look at the Telemed Caregiver Teleconnection, there is a link to a website. She provides a newsletter that has a lot of information as well as events that are going on around here. So I will gladly turn it over to you.
Thank you, Xanda, and I appreciate y'all having me here. Quick clarification, the term I use is pre-disabled, and I'll cover that in just a second.
Okay.
But before we get started, I owe everyone an apology. I've been developing this topic for a long time, and we selected it for today months ago, so I'm confident that we're going to fill this hour quite well. However, once a caregiver, always a caregiver. My partner's dad has been in and out of the hospital with leukemia the past few months, in particular an unplanned trip just last week that he's not home from yet. And as a result of all of these trips across the Metroplex, I haven't gotten the slideshow where I want it, and I've decided to skip it. I have a few intro slides and a closing slide, and I can leave the agenda up if it's helpful, but for most of our time together, you're going to be stuck looking at my face. I'm sorry that things worked out this way, but I hope as fellow caregivers, you'll understand.
And I think everybody does. And if I can jump in right here, as you're speaking, I'm going to go ahead and keep some notes and perhaps send out to our listeners some bulleted tips as you identify those during your presentation. And then we can follow up later with your slideshow. Okay?
Sounds great. Thank you, Xanda. And my slides are moving for y'all? Okay. As Xanda said, I'm a queer, white, pre-disabled caregiving educator serving at the individual, community, and national levels. I was a solo full-time caregiver for my adoptive grandfather, Ed. I got burned out, decided what I needed to heal was to change my name, embrace my queer identity, and get a master's degree. I've since facilitated the workshops that she listed, and about a year ago, I struck out on my own, and I'm eager to collaborate with organizations across the country, so tell a friend. I want to thank Xanda and Caregiver Teleconnect for having me back. This is actually my third appearance here. I was here in 2022 to talk about the Pride of Aging with Dr. Man Hansen, and last year I presented on family diplomacy. I spent a lot of time seeing what other programming exists for caregivers so that I can try to create something new and have something that would have been useful when I was caregiving. And in that vein, I did not just research, I actually sat down and talked with some medical experts, with some medical practitioners who are themselves or have been caregivers. So I also want to take a moment to say thank you to Dr. Alicia Lay and Elizabeth Patton, who is a nurse and also my sister-in-law. Their feedback has been invaluable on this. And here's that agenda that I was telling you about. I know some folks are just here for tips and they want to jump right into what's useful. But me, I'm an information person. The more I understand what's happening in a situation, the better I can adapt to it. So I'm going to start y'all off with some very basic context on medicine in 3 sections. This is going to be about half of our presentation. And then by 12:30, Central Time. I'll make sure that I'm moving on to the tips. We'll focus on the tips for a while, and when I'm done, there will be time for questions and answers. Quick recap of the sections will be medical education. We're going to talk a little bit about the training that doctors and nurses and other practitioners receive. Medicine as a culture. We've all heard of like office culture, right? Or the culture of a city. It's the culture of a state. It's like the personality of a bunch of people in a single place. Well, medicine has a culture also, and we're going to talk about that a little bit. And we're going to talk about medicine as a system. Most of us are no longer driving into town to see one physician for all of our needs. The past couple of decades have radically changed the ways that doctors work and interact with their patients. And there are advantages and disadvantages to these systems as they get bigger and more complicated. We as caregivers can understand that and adapt to it. So then we'll get into the tips, like I said, um, and I'll break it down into when you'll need them. Kind of a planning ahead section, typical appointments, everyday interactions. So you go in for a doctor's visit, or someone is staying in assisted living, or some sort of other residential care. Those kind of, scheduled appointments. And then when your loved one is in the middle of a crisis, is a whole other context, right? And finally, we should have time left at the end to take some questions. Any questions about the agenda? Okay, I'm going to go ahead and stop sharing, and you're just going to be stuck with my face for a little while. So on the topic of medical education, I think it's easier to talk about this in terms of myths. So let's talk about some myths about how we think doctors are educated or how they're trained, how they're taught. Um, I think the first one we want to start with is that doctors want to and are obligated to help people, that they're sort of taught to put the patient first in kind of a vague, non-specific way. Um, First of all, I just want to point out medicine has historically been one of the one of the most prestigious and high-paying jobs. Doctors can be motivated by status and income as much as any other job. There are a lot of ways to help people. So choosing to be a doctor often you're talking about status and income as well. And it doesn't detract from the willingness to help people, the eagerness to help people, but it does complicate it a little bit. And so I'm not saying doctors don't want to help people, but even the Hippocratic Oath focuses on do no harm. So don't make it worse. Their job is maybe a little different than we might perceive it from the outside. Our lifestyles are also very different from how they were just 30 years ago. So there have been a lot of medical questions emerging that don't have straightforward solutions. When we go to the doctor, how often is it as simple as a broken arm, a cut that needs stitches? It's very rarely that straightforward. We have to do the blood tests. We have to talk about our medical history, all of that. So very rarely is something simple and straightforward for doctors themselves. And then the other aspect of this aspect of how doctors help people is that hyper specialization in medicine has just been all over the place. And so many doctors are focused on just one thing. And I'm going to talk about that a little bit more later. But that also means that there are fewer doctors to fill the traditional role of general practitioner. Rural and low income areas suffer the most from this. Next myth I want to dispel, or at least address, complicate, is that doctors are trained in aging, disability, and disabling conditions. Now, doctors who do not specialize are not likely to learn much about specialized field. So if you may have heard of some of these specialties, these are the kind of things where you have to get specialized training. Geriatrics or geriatricians are doctors who specialize in older adults. Neurologists specialize in nerve and brain disorders. Rheumatologists take on a lot of the chronic and complex care that has been emerging for the last 20 years, 20, 30 years. And pain management is its own field now. And sometimes these specialties don't always interact with each other as well as we might hope. Even specialists can become hyper-focused on a single condition. You might have a neurologist who specializes in dementia or neuropathy, but doesn't really deal with both. Or Specialists can also fall behind on chronic and co-occurring conditions. I went to an orthopedist a few years ago. I had an old knee injury that flared up, and I asked for a prescription for physical therapy, and he just kind of shrugged and said he'd take my word for it because he was really more of a knee replacement guy.
Oh, mhm.
Doctors are not generally taught the human body in a systemic way. Remember how in health class we learned the circulatory system in one chapter and the digestive system in a different chapter, and then muscles and the skeletal system in another chapter. Doctors learn a lot more details, but they still learn in that same fragmented way. It's actually can be quite controversial when doctors try to address multi-system conditions. And it has only started to emerge again in the past 10 or 20 years as something that's taken seriously. It is not widespread at all. Subjects that doctors are taught for 4 or fewer hours, and this varies by state. But most doctors, especially when they first come out of medical school, will have 4 or fewer hours across their 10 years of training on dementia or other specialized conditions, mental or behavioral health, nutrition or diet, public health or epidemiology, cultural and LGBTQ plus sensitivity, policy and program development. So not just the practice of healing people, but of developing ways to do that in collaboration with communities, or they don't receive any training on that. They have to seek it out directly. And of course, navigating insurance, which is a constant process in the medical field at this point. Perhaps the most important thing to know about doctors' educations, doctors are trained to project confidence. For a long time, it was believed, in simpler times perhaps, that it was just as important for doctors to put on this air of calm and kind of paternalism and certainty with everything they did. If they had to ask questions, if they were uncertain about something, they were supposed to do it behind doors so that when they interacted with a patient or a patient's family, they came in with one solution and acted like it was the only solution in the world. That training has softened a little bit over the years, but it's a culture. It's deeply ingrained in medicine, and it's not an easy habit to break, especially for doctors who either have gotten a more old-fashioned training or have been at it for a long time. Their intelligence and their calm demeanor was supposed to soothe patients' doubts. The idea was being at the doctor's office or at the hospital could be a time of uncertainty. And so they were supposed to combat that. Unfortunately, we do see sometimes that that confidence is a little hard to break past. And we're going to talk about that in the tips section. Um, I think we also are all aware that doctors can talk fast. So that's something that we want to be aware of. We are within our authority if we have to either ask a nurse to repeat what they just said, or ask the doctor to slow down, or to even give it to us in writing. Um, the good thing about there being so many electric records is that almost every interaction we have with a doctor has to be written down by the doctor, and they can just send us their notes. And again, I'll mention a little later about the patient portal, but the patient portal can be your friend in that regard. If you're not overwhelmed by looking through a lot of medical paperwork, you can find the doctor's notes on what's going on and on which interactions, so that you can get clarity if you have questions or need to find out how to spell that obscure medicine you just learned existed. One thing I do want to point out, I'm talking about some of the lesser known aspects of being a doctor, but I do want to highlight that these things, we may think of them as these traits may detract from our impression of doctors having this bedside manner. Um, I think it's complicated. It doesn't mean that there aren't doctors out there with a wonderful bedside manner, but it also means that we need to keep in mind that just because a doctor doesn't necessarily demonstrate a strong bedside manner, it doesn't mean they're not skilled. It may be that they're seeing the 20th patient of the day, and they're really just trying to be efficient with their time. So we've talked about doctors. Let's talk a little bit about how nurses are educated. Um, Nurses, I think there's a myth that nurses are less educated and informed than doctors. Doctors, on average, hold more of the medical knowledge, but nurses hold more of the knowledge of operations and application, including patient and family information. They have to be experts at the computers in ways that sometimes the doctors don't have to be. I like to think of it as depth versus breadth. The doctor is going to go really deep on a very narrow range of information. The nurses are going to have all of the functional information that makes that depth impactful. Where doctors tend to specialize and work with a narrower type of patient after a few years, nurses usually have to be prepared for any patient and any doctor who walks in the door. Nurses can specialize. They have degrees all the way up to doctorate of nursing or PhD of nursing. So we want to keep in mind, just because we're interacting with a nurse doesn't mean we're not interacting with a doctor at the same time, or at least someone who has received a tremendous amount of extra training. There's all kinds of levels of nurses. Um, I think historically we think of nurses as assistants for doctors. They're just there to kind of hand them tools in surgery or whatever. It's not that way. It hasn't been that way for a very long time, if you could say it's ever really been that way. The more that medicine specializes, the less this becomes true. Um, Nurses have also become more like the stage crew of a theater or an operations team for a large company. Doctors may lead the medical decisions, but nurses have tremendous input. Nurses are responsible for logistics, information, and communication. They also take vitals, they keep records, they double check prescriptions. Sometimes they're the ones calling the prescriptions in. They're responding to emergencies as well. I think especially when sometimes we see these depictions on TV, if they're not showing the doctors as superhuman, they might be showing the nurses as superhuman. This well of compassion that keeps hospitals sensitive. But nurses can also be jaded or tired as well. And I think the last myth we want to address here is that it's not just doctors and nurses, is it? There are many types of medical professionals, and each carry their own unique background, training, and hierarchies that vary across every hospital, clinic, and doctor's office. We've got nurse practitioners and physician's assistants. We've got nursing coordinators, pardon me, and care coordinators. We've got medical technicians and imaging technicians. We've got physical therapists, occupational therapists, speech therapists. Um, and just, I know a lot of us who are here have dealt with dementia, cared for someone with dementia. People with dementia tend to overdo it and hurt themselves if you put them in physical therapy. So that's something that a physical therapist might know, but we as caregivers can catch and observe and intervene on before it happens. Caregivers can help with boundaries and building long-term benefit of any of these interactions. There's also social workers, there's case managers, there's office and billing managers. We don't really want to hear from them, but they exist. And there's when we get to end of life, there's hospice, there's palliative care, and there's death doulas. And those are all very different concepts that overlap. A question I'll put out to y'all is who else might we encounter in a medical setting? Because I don't think that was an exhaustive list. Do you? So let's move on to talking about medicine as a culture. There's a concept that we use in academia that I think caregivers understand more than anybody, and that is this tension between cure versus care. Cure versus care. I could spend a whole hour on this theoretical framework that's emerging, cure versus care. It essentially posits that doctors are only really prepared to address one condition at a time, and the vast majority of the time, they're not trying to fix root causes or make the person comfortable. They're trying to cure the one thing that's wrong so the person can resume normal activity. They are trained this way. And again, this is something that is changing, but it's changing slowly. Um, if you go back to the very early days of hospitals and clinics emerging in France in the early 1800s, it's fascinating how much early medicine overlaps with ideas of colonization that were happening at the time. I sometimes think it's helpful to frame medicine as colonization of the body. Here's a territory that isn't acting how we think it needs to act, and we're going to fix it. We're going to cure it. We're going to fix that one problem so that it behaves more predictably. Um, the care model, by comparison, is closer to the tradition of nursing. It's helping patients be comfortable. It's thinking about their quality of life. It's working with families and caregivers, figuring out how co-occurring conditions interact with each other. It's confronting the ethics sometimes of decisions that maybe there's no win scenario, but you can choose, a comfortable path or an aggressive treatment plan, something like that. These all fall under the care model. And of course, that's where we as caregivers spend most of our time. Um, so we don't always understand doctors, and doctors don't always understand us because they're coming from that cure model. And we're, pardon me. And we're coming from that care model, and they're coming from that cure model. Some of this has become necessary, especially tracking drug interactions. There's always going to be some level of monitoring and cross-referencing that happens now, but it's still relatively new in the history of medicine as we know it. And then I want to talk about doctors as human beings, and they have subjective influences like any other human being. In fact, let's not even talk about doctors first. Let's talk about science. Let's talk about medicine as a science. I think we like to think of science as something that's decided and concrete, and we might learn some new things, but the old things never change. But science doesn't really work like that. Science is what we call an iterative process. It's cumulative. It shifts over time because A, sciences have culture, just medicine has a culture, physics has a culture, sociology has a culture, and because we will learn to reinterpret old information in new ways. It's not necessarily that old theories get thrown out, it's that they get recontextualized as we learn more information, as the information bank that we're operating from expands. It just turns out that that was true, but it was only true 80% of the time, or, when you're looking at something on the planetary scale versus the galactic scale or something like that. So that iterative process means that there's always new stuff being added to it. And there's tension with that process. New information doesn't just get slapped on like a patch. It has to be debated. It has to be argued over. It has to be proven, disproven, tested. And it can be a very slow process for something to be taken for granted within a field. So it's never the final word. There is no final word in science. We've never found any science, biology, medicine, physics, none of them have ever stopped making new discoveries. So when we're in a hospital or when we're a doctor's office and we have a complex mystery, your case may take time, but it's like detective work. It's supposed to take time because they're ruling out a lot of other possibilities. And they're trying to again, they're coming from that cure model. So they're trying to see what is the one piece of information, or what is the one thing that needs to be fixed, and then how do we fix it? So they have to gather all the information in order to do that. And sometimes we have to wait. And I think we're a lot less patient when we're engaging on behalf of a loved one than when we're doing it for ourselves. I think, if I went into a doctor and they said it's going to be 2 weeks to get this test, oh yeah, whatever. But if I'd gone in with my grandfather and they said it was going to be 2 weeks, I might have been appalled. How dare you not move faster on this person that I love? That's something that we bring into the room, and it's something that we can be aware of and maybe turn it off and turn it on as needed. Doctors do have continuing education, but they have a lot of topics to choose from and a lot of discretion about where to focus. Again, even within general practitioners, you'll see some level of specialization. Some of them mostly focus on families of teens and parents, and maybe they don't work with older adults as much. Or they may specialize in older adults, even if they're not an official geriatrician. Or they may specialize in healthcare in urban settings, and someone comes in with a farm injury and they're just like, I have no idea. I haven't seen this since med school. Um, so all of that is just reiterating that medicine is a culture, and with all of that constant process, that iterative process of change, doctors, just like anybody else, can be resistant to change in their field. The most glaring example, if you ever want to look this up, is this guy named Lister invented disinfectant and suggested that we should start disinfecting our hands and the operating room before surgery. And he died broke and penniless, and uh, was not taken seriously for the rest of his life. It took decades for people to start listening. And we couldn't imagine going into a hospital setting without disinfectant, without you wouldn't want a doctor not to wash their hands and put on gloves before surgery. Like, it's just unheard of at this point. But it took a long time. There was resistance. Obviously, that was in the distant past. A more recent example is these conditions that are sort of lumped together, and I'm not even going to try to say the full name, but MECFS. CFS is chronic fatigue syndrome, but MECFS is this sort of category of conditions that were barely taken seriously. They were just starting to be taken seriously as these chronic ailments before COVID hit. And then we've seen a surge in research in ME and CFS because we've learned that COVID can create ME CFS like symptoms. Long COVID and ME CFS overlap significantly and may ultimately be proven to be the same thing. So that's a much more recent example. This is an ongoing process. Doctors' behaviors, this is a kind of a new direction. Doctors' behaviors may have a lot more to do with policy that they have no control over than ever before. And I'm talking about government policy. I'm talking about corporate policy if they're in a hospital system or a giant partnership, insurance policy. All of these things affect how a doctor can do what they're doing. If they don't go about it the right way, they may experience timing delays. They may have to wait on imaging or scans that take longer than they would like for it to take. They have other external forces to deal with constantly. So keeping up with these rapid changes in law at the federal, state, and local level becomes its own form of continuing education. You also have professional associations. You have emerging research. Honestly, most doctors, unless it's in their specialty, like that emerging research is kind of an afterthought. It's just not going to make it in there right away. Um, and then, uh, doctors are human beings. Again, nurses are human beings. They have values. They have lives outside of the clinic, outside of the hospital, outside of the doctor's office. They have their own politics. And maybe it's best if we not discuss politics with our doctors sometimes, because I was recommended by one of my advisors on this to point out not to add our own politics to the mix. We don't need to debate doctors about what we saw on TV or what we believe. We just need to hear out their perspective from the medical perspective, and we can agree or disagree. And we can say, we're going to pursue this line of treatment or we're not going to pursue that line of treatment. So yeah, doctors are human. Who'd have thunk? We like to think that they're above politics and financial hardship and even illness, but that simply isn't the case. I'm going to skip ahead and talk about medicine as a system very briefly. Um, Medicine is a business. A doctor's office may not run all that differently from how it used to, but it still looks very different. Just a lot more staff to keep up with everything. Running a medical office is its own specialization. You need nurses who specialize in that sort of thing, and sometimes you need office managers and non-medical practitioners who specialize in that kind of thing. And if you get one of them on the phone, if you get a billing technician on your phone and start trying to ask questions about the condition, that's going to confuse them, that's going to confuse you, and you may not be able to connect. It's frustrating. It absolutely is. And so sometimes if we're on a phone with someone from a doctor's office and we don't know for sure that it's the doctor or the nurse, we may just want to ask, are you someone that I can ask medical questions? Um, anyway, the more overworked the system, the harder it gets to practice good medicine. I have learned in recent years that doctors, not personally, but I've witnessed doctors can fire clients not because of insurance issues or lack of payment, but just because they find a client difficult to work with. It's rare. It's not always kind, especially when there aren't many people offering that specialty locally, but it does happen. So we want to keep doctors on our good side. So alongside all of this, the big elephant in the room perhaps is that hospital and clinic costs have been skyrocketing for decades. There's a bit of history here. It turns out that a lot of that started with the passage of Medicare. Not that Medicare was a bad idea, but some of the ways it was implemented allowed for what eventually became kind of a price hike strategy, and efforts to contain those costs kind of came in too little too late. And so we're still seeing this sort of rampant, the cost of healthcare has skyrocketed way faster than inflation over my entire lifetime. Medicare passed in 76, I think it was in the 70s. Um, so something to be aware of is that it hasn't always been this way, but it is this way, and it's just as frustrating for doctors as it is for us. Um, Another thing that we see with all of these skyrocketing costs is that hospitals, specifically hospitals, hire way more administrative staff than they used to. There's line graphs of this. It's very fascinating, where like the number of doctors and nurses hired on goes up kind of gradually. It's kind of close to the rise in population for their area, but the number of hospital administrators just skyrockets. It just blows everything else out of the water. And so all of these consultants and helpers are a big contributing factor there. Um, we also see new technologies and pharmaceuticals emerging constantly. The FDA has this process, and everyone's frustrated because some people say it's too thorough, some people say it's too slow, and yet we have recalls almost every year now of something that made it to market, and some aspect of it wasn't adequately researched, or sometimes even the research was fudged. So it's complex. It's just as frustrating for doctors and nurses as it is for us. It's important to know that to get FDA approval, a technology or a pharmaceutical only has to be proven effective against doing nothing. It doesn't necessarily have to be proven more effective than existing medicines. It doesn't have to be proven affordable, and it doesn't have to be um, it doesn't have to be proven to be superior in any specific way to what's already in the market. That's where advertising comes in. So if you see a splash advertising campaign for a new medication, it may be revolutionary. It may be brand spanking new, something that's never been done before and achieves miraculous results. Or it may be a cheap underperformer compared to stuff that's been on the market for 30 years, but the advertising is there, the budget is to promote it is there. um Again, like, I don't want to make people scared. Like, this is frustrating, this is annoying to deal with. uh but it's stuff that complicates the systemic approach of doctors. They're having to navigate all of this the same that we are. Often administrators, especially in hospitals, have the final word. So we think of doctors as being the authority. And if I say so and so needs this procedure, they need this procedure. But if the hospital administrator says no, or the insurance company says no, like you really may not have a lot of options. I did also get the tip from one of my advisors to fill out surveys from hospital stays and doctor's visits to help get your providers raises, especially if you have a good experience, you want to report that. Okay, let's move on to our tips section. This is going to go a little bit faster. This is the meat and potatoes, so feel free to start taking notes at this point. I just want to give you a background. Um, Medicine is a very complicated, dynamic system, and we forget that our place in it is sort of an afterthought. There is no place built into medicine for caregivers. We're just sort of proxies for our loved one. And if we understand the system that we're interacting with, sometimes it can help us be less frustrated, um, or at least direct that frustration toward factors that are outside of our doctor's control rather than being mad at the doctor themselves. So, tips. I'm going to start with tips for planning ahead. And so this is going to be general planning ahead, and especially if you've got an upcoming appointment and you want to prepare for it. Keep notes on little changes before they become big changes, and keep your notes organized. One tip that I learned from another friend who I didn't cite, it's helpful for some practitioners if you tell them how this new symptom is making a person's life difficult. Some providers may not take a symptom very seriously if you can't also say, it's affecting my sleep, it's affecting my diet, it's affecting my work, it's affecting my family. They need that correlation to be drawn in order to understand it and take it seriously. So be able to articulate quickly, I am feeling this symptom and this is why it's bad for me or for your loved one. Prepare your notes ahead of appointments and try to focus your questions in just a few items. There's nothing wrong with drafting it down and you got a whole paragraph, you got 10 lines. It looks like my notes for the slides that I didn't get finished, but you want to pare it down. You want to simplify it. You want to go in with just maybe 3 to 5 most important questions and maybe some afterthoughts or secondary questions that fall underneath those. Caregivers are notorious for talking too much because we're overwhelmed. We're also isolated a lot of the time. It's not the provider's job to take care of us, but it's really, this is where all of those self-care practices, which can be a million other presentations, that's where they come in, that we need to have other people we can talk about our loved one's medical condition, whether it's a medical forum, hopefully nothing too quacky, but a loved one or a friend who has been through a similar condition or a similar caregiving dynamic, just someone who gets it, why we're frustrated with the doctor about this medication or this surgery that keeps getting delayed or whatever it is. We don't want to take that frustration into the room with us. Even journaling is better than nothing. That's like having a conversation with yourself. Highly recommend it for self-care. In your notes, you want to include past medications, as well as any history of like substance abuse, surgeries, all kinds of details. You don't necessarily have to have it on the front page, but have it available in case the question comes up. And especially you want to keep track of medications that your loved one has tried in the past that maybe they didn't work or they caused adverse reactions, because you're going to be seeing new doctors, especially if you go to an ER or an urgent care. You're going to see a doctor who doesn't have their whole history in front of them. They're not going to know that something bad happened. It may not have been an allergy. It may have been they started hallucinating when they took this med. You have access to that information in a way that they don't. So another tip is to keep an ear out for magic words. This is kind of my term for, you can say the same thing in different ways, and the doctor may only pay attention if they hear specific words. Um, an example is my grandfather was experiencing peripheral neuropathy along with dementia, and we went in talking about his feet burning for an entire year, and the doctor just skimmed it over. I don't know what you're talking about, whatever. And then um, he talked about tingling, and I don't think that registered. But at some point, he said that we talked about numbing or like pins and needles or something. And as soon as the word pins and needles came up, the doctor like perked up. It's like, oh, you're describing peripheral neuropathy. We need to get that checked out. So uh, it's frustrating, but this can be where it's helpful to do a little bit of research. We don't need to go down the rabbit hole and try to trust Dr. Google with everything, but we can find similar words that describe what our loved one is going through and find what is the preferred medical terminology for it. And just have an idea of how other people describe it. Sometimes the words we use just don't match the doctor's expectations. This one is real quick. HIPAA, the famous privacy law, is built around insurance companies and who is or isn't allowed to have access to your health data. It only applies in one direction. If your loved one filled out paperwork before you were caregiving for them that didn't include your name, you're going to have to get your name put in there somewhere in order to have access to their records. But that rule only applies in one direction. There's nothing stopping you, your neighbor, your cousin, anybody else, if it's relevant, from slipping a note to the doctor, sending an email, calling the nurse's line, and just leaving a message and says, this is most helpful, I think, when we're dealing with someone who has dementia and doesn't want to get diagnosed or won't acknowledge that they're dealing with cognitive decline. We can slip a note to the doctor and say things that maybe we can't say in front of our loved one. Um, we want to identify in advance of a crisis what is our preferred emergency room, what is our preferred urgent care, what other potential emergency resources might we need to use. We want to know what insurance they take and what paperwork they might need. If you're looking at end-of-life care, or even if you're not and you just need to file do not resuscitate, you need to file your power of attorney, all of that stuff. If you have already established a relationship with that hospital in advance, you can file that paperwork with them. It's still a good idea to take a hard copy with you because not everyone's going to send a clerk to go find that paperwork, but it can expedite things to already have it on file. Again, use your access to patient portals. I don't need to repeat that too much. Have a system for communicating with other caregivers. If you're not a solo caregiver, which unfortunately many of us are when we're caregiving, your loved ones' siblings, their children, neighbors who are very involved, friends, how often do we check in with them? How much do we tell them? And who's going to back you up if you get sick? It's really good to have a plan for all of that. And then what changes if your loved one goes into a facility or under hospice? This again could probably be a whole other topic of its own, because the rules change. You have to get a doctor's approval to go into memory care. A lot of people don't know that. And then once they go into memory care, sometimes the communication is not as good as it should be. You may get a call that they say they're taking your loved one to the ER. Or they may take your loved one to the ER because they've had a fall and they need to get checked out, and they don't call you. It's really good to ask these questions early and often with facilities. What does communication look like? How do I know you'll let me know if there is an emergency? So let's move on to scheduled interactions. And I know we're getting short on time, so I want to make sure we have a little time for Q&A. Tips for scheduled interactions. So that's doctor's appointments or regular check-ins, care planning with the facility, anything like that. Whenever possible, let your loved one speak for themselves. They may need to hear, the doctor or the nurse may need to hear what's happening in the person's own words, if they're capable of using their own words. If they're not, if they're just super quiet, of course you do that. And then when they're done, you can add anything that they've left out. You'll know better than the doctor will what to say and how to say it. Also encourage the doctor or nurse to engage with your loved one if that is something that they are capable of. unfortunately, we have seen that doctors in particular will think that someone with dementia has just completely checked out, which is strange because they should, again, they haven't gotten much training on dementia. They may not realize that it's a gradual cognitive condition and that many people with dementia are still fully engaged for a significant portion of their cognitive decline. They just might need simpler sentences. Their attention span might not be the same. They may not remember the conversation, but they're still capable of engaging. And as long as the caregiver is there to take the notes and to fill in any gaps, it's useful to have them speak for themselves. This is also especially true for mental health. We really want practitioners to speak to the person who is experiencing the symptoms and hear it from them. We can add our own thoughts after the fact. If there's a new symptom or series of symptoms, describe the symptoms, not your theories about what's causing the symptoms. I've been a little guilty of this myself in the past for my own health, not for my grandfather's, but yeah, describe the symptom, not our theories about what's causing it. We should be able to take our time and have a thorough conversation in the doctor's office. This isn't going to apply when we go to the ER or the urgent care, but in a doctor's appointment, a regular routine checkup or a, hey, there's this thing, we want to get it checked out. You should have the time to ask questions, to get all of the information that you're looking for. Save your questions until the provider has finished their assessment. They may have a protocol that they're going through, and it's important for them to get through it before and they may end up addressing your questions, but if they lose their rhythm, lose their flow, it just slows everybody down. If it doesn't come up, if your loved one doesn't say anything, if the questions don't address it, then you could say, hey, by the way, we haven't discussed this issue, but it's also occurring. Another big tip, nurses are your allies. It's a lot easier to make progress with a difficult doctor and a friendly nurse than the other way around. And something else is the goals of care. This again goes back to that cure versus care model. What are the goals? What is it that we want to accomplish? Because doctors and caregivers don't always have the same goals. Again, they may be looking to fix something. Dementia is a great example of something that, we can alleviate symptoms. We can reduce risk of someone hurting themselves. But we, as of right now, don't have a cure. We don't have a way to make it go away and fix it per se. So we want to be practical. A full recovery is not realistic. What are we looking at in terms of quality of life? Many non-dementia caregivers also underestimate the intensity of full-time care. If someone can't get around for a few weeks or anymore, they may not recognize how much of a burden they're taking on, and how much support they'll need. Doctors may also sometimes just be kind of fixated on whether or not they have a DNR, a do not resuscitate, but there are other gradients of care to navigate. Okay, last section, crisis interactions. This is when you go to the ER, when you go to the urgent care, be prepared with that vital information. There's lists out there of information that's good to take to any doctor's appointment, but especially you want to take it for an ER appointment. If a new symptom emerges, try to write down the moment that it happens. If you think someone's having a stroke, if someone has a fall, if someone starts speaking gibberish, try to write the exact moment that you noticed it happening, because that information is going to be important later on. You'll need a list of medications, allergies, all of that stuff. Take your list of questions, but let the practitioner lead the conversation. If you need an interpreter, don't wait. Request the interpreter as soon as you arrive. Don't settle for a young relative who's kind of bilingual, but maybe doesn't know all the medical terminology. Get that interpreter. Get that interpreter. And so I'm saying this as much for professionals as for caregivers. And as I was saying a second ago, let the professional guide the conversation. They may have a list of questions they're asking. They may have a protocol. They may have a computer prompt. You may start asking them questions that they can't answer because they're on this page on the computer, and the answer to that question is 5 pages over. So we want to listen carefully, let them guide the process, especially in an emergency. Also, this is one of those situations where the calm that they can project can be an asset for us. Let them be calm. Let them slow us down a little bit. Catch our breath. They're in good hands. Um, don't expect any provider to be superhuman. I mean, that's really what it comes down to. I know we've just got a couple minutes left, but do we have any questions? I'm going to share this
You're,
again.
you're muted, Zanda.
Um, Something I'd like to add, um, especially in facilities, as a caregiver, whenever possible, if the person is under care by a doctor, especially a specialist, uh, we ran into this when my husband was on multiple medications, which is very common, and the facilities just flat refused what I was telling them. I had the list, and they just flat out said, you'd never give medications like that. So that taught me that when we next saw the provider, I asked for a written order. And sometimes that can be very helpful, especially in an ER, especially if you are transferred into rehab from a hospital. Everything you can get in writing, and you've done such a good job about talking about writing, put it in writing, put it in writing, put it in writing. Very often caregivers have to carry a little notebook of all these things in writing. And another comment about the surveys. It was late getting my survey in, but first page was about talking about the quality of the nursing staff, how positive. And at the end, I put addendum. So it wasn't a yes, but. And the second page was the issues, including a fall my husband took unnecessarily. And there were several, delays and that kind of thing that happen in these places. But again, I guess my point is everything that you can take with you or do in writing makes a tremendous amount of difference. Even writing up those symptoms in bullet points and giving it to the front desk when you check in and ask them to put it with the chart. Very frequently, they'll say, no, 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 give it to, because there's usually somebody you see at the beginning of before you even see the doctor. But get it in writing, get it in writing, get it in writing.
Well said. You mentioned getting an authorization from the doctor. That sounds like advice that you may have gotten from an advocate or one of these
Nope.
other specialists at a
Right. Well, but
hospital,
that
these
does happen.
advocates or
Yes, that does happen. But that actually happened. It was just something I had to learn because
yeah.
I was tired of having the same discussions over and over and being told basically that didn't know what I was talking about. So it just solved everything. I just had a copy and I just handed it to him. That stopped the discussion. And by the way, those of you that are still with us, there is a session survey that will tell us just a few questions and will tell us about your responses to the session today and teleconnection overall, and any information you can provide us about future speakers would be very helpful. Before we let everybody go, I've been looking at Thomas says, excellent presentation. Thank you. I don't see any particular questions, but if you could, in the next minute or so, can you kind of summarize, if possible, the message that you want us to walk away with?
Absolutely. Be prepared. I mean, a lot of the note taking and the record keeping and all of that it often just comes down to be prepared before you're in a crisis. Don't treat practitioners as superhuman. Um, they're just human beings who have a lot of technical knowledge in an area that we become dependent on. And that can be scary, that can be intimidating, but it doesn't It doesn't have to slow down the support process. And I guess the other tip I would throw in there is know your limits. Like I said at the beginning, I'm a very information oriented person. The more information, the better. I draw a lot of calm from understanding the complete the lay of the land. And not everybody is like that. Some people get overwhelmed with too much information. If that's you, or if you tend to go into a doctor's appointment and come out completely exhausted, notice that and see if there isn't a better way to either interact with the doctor or to bring in other caregivers, bring in extended family or someone who may be able to help you take the notes, record the conversation, keep the paperwork organized. Just someone who can take some of that off of your plate so that you can focus on what you can handle and you're not trying to do too much, because doing too much is a fast path to burnout.
Mhm. Mhm.
Those are my 3 big takeaways, I guess.
Great. I have been taking notes and I will send those to you for you to look over and add to and whatever, so that we can distribute that to our listeners. And then as time permits, in your caregiving journey, maybe you can finish the slides that you had been working on and we can distribute those later. I hope for everyone, this has been a valuable hour that you have spent. Obviously, on almost any of these areas, we could spend an entire session just on appointments, just on basic skills of talking with the healthcare providers. But this is a good overview. All of you have a story, and we realize that you could add much more to this conversation. What you learned, what you wish you'd done differently. All of us have had that in experience also. But take the information that you've heard today, share it with others, think about it, and anything you want to let us know about. Again, thank you so much, GJ, for your time today. And I know I would get emails from him saying, I talked to so-and-so today, and I want to add this to the presentation. You've just really been committed on trying to provide the most information that you could on this topic. So that said, if you would, everyone, complete that survey. It takes very little time. Thank you, everyone. Take care of yourselves. I know you hear that a lot, and sometimes we don't know how we're going to carve that out. But again, if we don't take care of ourselves, who will?
Well
Have a
said.
great Monday, and we will look forward to seeing you next month. In November, we will be talking about caregiving, family caregiving, and the holidays. We start that in November because it starts. It's already started. Just look at everything that there's already Halloween things out. So take care. See you, and look forward to hearing from you soon. Thank you again, sir. Yeah, bye.
Thanks, everybody.